It's my pleasure to introduce Dr. Ahmed Mohanker from the National Blood Transfusion Center, who will give us a presentation about regular packed red cell transfusion protocols, a therapeutic unit in NBTC as serological point of view. تفضل.
First of all, I'd like to thank you for for inviting me to give you my presentation. We go through this lecture for the basics of the regular blood transfusion protocols at therapeutic unit in NBTC as serological point of view. We go to the depth of our work, blood group antigens and antibodies for the basics, ABO system, RH system, and other blood group systems. The ABO system is the most significant transfusion practice, the only system that has naturally occurring antibodies, most typical, uncomplicated, but anomalies will be encountered and should be recognized and resolved or referred as discrepancies. ABO discrepancies, we do blood group to reach discrepancy. We do all blood groups by at least two methods, forward or direct method to reach the ABO antigens, reverse or indirect method to search for ABO antibodies. Both methods must give the same results, or otherwise there will be discrepancy and cannot be applied to the group. Like here, the anti-A, if there is no antigen A or B, it will be anti-A cells reaction and anti-B cells reaction. It will be O blood group. Otherwise, A antigen will be A blood group, or B antigen will be B blood group. ABO anomalies, when expected to have forward and reverse ABO groups not matched, ABO discrepancies occur. Can be divided into four groups: missing or weak antigens, unexpected antigens, or weak or missing antibodies, or unexpected antibodies. Missing or weak antigens, unexpected antigens. Many causes like genetics, A or B subgroups, acquired, some diseases and transfusions or transplantation. False negative, antigens expression decreases. Example, acute myeloid leukemia and A subgroups A or X. Weak or missing antibodies, false negative, like extreme of ages in babies or old age, hypo or gamma agglutinaemia due to technical errors. False positive antibody, called agglutination or antibodies, A1 antibodies or antibodies against A1 in A cells, autoantibodies, fibrin, treatment of IG, passively acquired antibodies by transfusion. RH system is the most complex blood group system, and antigens are membrane separating proteins in the RBCs. 5 principal antigens, capital D, capital C, capital E, little c, little e. Antigens are coded in RHD or RHCE genes. D gene is the most highly significant immunological reaction. We also do weak D for the RBCs or partial D for the weak reaction of RBCs. The most important phenotyping of RH system is these five antigens. We know that there is a regular trend to give RH negative blood to RH positive, but this slide shows that if we give an letter R negative blood, we have here antigen little c to a patient with RH positive blood, which was R1, which is about 9% of people. It will cause anti-C. Okay, high incidence. The most important other blood groups, KIL, DOFI, and KID, SMNS, Lewis, and P. and Lutheran. Methods of RBCs typing: tube technique, microplate technique, CAT technique. I will call them agglutination, which is done in the national blood transfusion. Significance of blood group and antibodies. The importance of these systems lies in their immunogenicity. In order to immunogenicity, we can say that capital D, capital K, kill, and C, E, and E, and capital C are the most significant. Antibodies against these antigens can cause hemolytic transfusion reactions or hereditary disease of fetal and newborn. Okay, we do antibody screening for the donor and the patient and antenatal. Antibody screening for the patients: detection of clinically significant atypical antibodies, prevent hemolytic transfusion reaction, detection of hemolytic disease of newborn in testing of antenatal patients. Antibody identification for the patients, identification of clinical significant antigens. Antibodies enable to selection of the antigen negative blood for cross-matching and prediction of prognosis of hereditary disease of newborn. Antibody screening for the donor. We are looking for potent antibodies dilution when transfused. Selection of the screening cells. Minimum 2 unpooled cells, but we use usually 3 cells. Must contain Rh antigens C, E, D, E, and K. And most significant phenotype. This is the 3 cells. And this is the panel of the 3 cells. If there is any positive of regular antibody screening, we go for identification by using at least 8 group cells, 11 cells, another panel, which is look like this. Positive antibody identification. Example of common with discrepancy. This is the approach of our therapeutic to a new case in our therapeutic unit. Case 1, cassette method. We see that the direct group gave a group, blood group A, anti-A and +4, and the reverse will be blood group O. This is discrepancy. Tube testing, we repeat the test, give the same result, but no with anti-A2 cells. So we consider that it may be a subgroup. Proceed for antibody screening. It will be, it was +2 in 2 cells, in cell 2 and cell 3. So it is possible also to have another alloantibody. We proceed for antibody panel. It will have, the patient had anti-N antigens, antibody, alloantibody. So by repeating the test with anti-A cells with N positive, the patient give +2, and repeating the cells with anti-N negative red cells, the patient will have negative results. So final result, anti-N reaction at the body temperature and give the patient N negative RBCs, phenotype the directed donation. Okay. Case 2, another cassette testing, give O blood group, and the reverse give B. Tube testing by washing RBCs, both were B, so there is no discrepancy by the tube method. Proceeding antibody screening, there is negative antibodies, so it is missed antigen, not the problem is in the antibody. If there is missed antigen or weak antigen, we go to the history of the patient. If there is transplantation or massive previous transfusion, or A or B subgroup, leukemia, red cell aplasia, excessive soluble blood group, or chimeria. Mixed field, okay, for transplantation. So ABO antibodies are expected. The weaker reactions are typically apparent. History is very important to resolve these discrepancies. Until ABO discrepancy is resolved, ORBCs and the AB plasma should be issued. After selection of the unit of blood, the blood unit needs another process, wash. We do wash either manually or by buffy code removal, automated blood, filtration to remove the most of the white blood cells to prevent post-transfusion febrile reaction, irradiation if needed, if inactivate the lymphocytes, according to the patient diagnosis and the plan of treatment. Treatment of iron overload, as it is expected to have for expected result for repeated blood transfusion, we usually use Disfral and Ferrobrox. Now in NBTC, we have begun exaggerate treatment on the government expense under supervision of consultant hematology. Conclusion and recommendations: essential to have understanding of red cell serology. All blood transfusion dependent patients must be phenotyped once diagnosed prior to the first transfusion. Those patients must always receive RHKL phenotyped blood at least. Antibody screening must be performed prior to each transfusion in addition to the regular cross-matching. Pregnant females must routinely undergo an antibody screening test. If the result is positive, the antibody must be identified, processing the blood unit, wash, filter, or irradiation as needed, management or avoiding any expected complications, especially alloantibodies or iron overload. This is our references, and thank you. Thank you. شكرا.